rules is once upon a time that should.
All right, everybody, let's get started. The clock clicked on us. We've been doomed. This is the Medical Directors Committee meeting, GTAC, May 12th of 16. Welcome, everybody. I know Bradley's not going to be here. Is anybody else here? I'm here. Bradley's not here. Steve's here. Jeff's here. Sharon's here. Craig's here. Bill's here. Kate's here. Jared's here. Bob Gerhardt is not here. Dave Perch is here. All right. So the first thing on the agenda, Kate, if you want to talk about the pediatric recognition program.
Sure, absolutely. So I think everyone here at least knows who I am, but I do sit on the EMS for Children Advisory Council for both Texas and on a federal level. And one of the goals is how can we ensure that children are having their needs met with respect to emergency care. We know that when a child is taken to an emergency department, the public expects that that emergency department is ready and able to care for them. There have been guidelines in place for 15 years that were initially written by the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association that highlight the infrastructure needed to be able to care for children. And we're talking about basic infrastructure, patient care review process, so we know what kind of care is actually being delivered for children, patient safety measures specific to children, so that we ensure there's no misdosing of medications, certain supplies and equipment that should be in place, and general policies and procedures that should also be in place for children. There was a national assessment that was conducted in 2013 based on those guidelines to allow hospitals to complete a self-assessment to see how well they were in compliance with those guidelines. There was over a 4,000 hospital response rate, so all 5,000 hospitals in the U.S. and U.S. territories were invited to participate. 83% of hospitals participated, and the median score based on that assessment was 69 on a 100-point scale, suggesting that there are still numerous gaps that exist in terms of our nation's ability to care for children in the emergency department. The guidelines that were put out have been endorsed by numerous professional organizations, including the Joint Commission, the American Medical Association, American Heart Association, the Children's Hospital Association of America, among others. And based on this, we know that there's a need to be able to fill these gaps. Certainly, community hospitals want to be able to meet the needs of the community. Since that time, since actually 1999, before this assessment, a number of states have developed pediatric facility recognition programs. These would be similar to what we do for trauma, where we know that the needs are being met when it comes to injuries. How can we ensure the needs are being met in terms of pediatric medical emergencies? The great majority of these are voluntary, and it basically how well are these hospitals meeting the guidelines in terms of basic infrastructure. These facility recognition programs help in terms of improving overall awareness, but also in terms of improving readiness. And we know this from the national assessment that shows almost a 90 percentage point score for facilities that are recognized versus those that are not, which is closer to the 60 range. So we know that these result in improvement. And the ask from the Texas EMS for Children program at this point is, would this committee support in concept the idea of pediatric facility recognition in the state of Texas? If that is the case, then we would move forward with working with stakeholders to develop an implementation plan and timeline. Those discussions have already been started with chat with TPS, which is the AAP's chapter here, the Texas ENA, the RAC chairs, TTAF, the Texas Hospital Association, among others, including Torch, which is an important stakeholder to mention. So all of these stakeholders would be involved in developing a plan for how this might look in the state of Texas, but we do know it would be very individualized to the needs of our state and the individual communities.
So how would a hospital know, would they have a plaque or certificate, or how would they be recognized?
So that's a great question. How would a hospital be recognized? And I think that would be what the stakeholders would hopefully input. Would it be a sticker they put on their door? Would it be some other form of recognition? It's different among every state in terms of how that would work.
What works the best of all the states?
What works the best? I think that's a good question, because I don't know that anyone's really assessed with the recognition piece of what that looks like in every single state in terms of, you know, what works the best. But I think some form, you know, in California, they have what are called EDAPs, Emergency Departments Approved for Pediatrics, and they truly just have a sticker that's put on the door of the emergency departments that says, you know, we're approved for pediatrics.
So, I mean, I think that ought to be a part of our plan, is to, if we decide to go that way, is to make it significant enough that a hospital would say, well, this would really be nice. Even if they put it in their ads on the Sunday paper or whatever, it would be nice.
Yeah, absolutely. And it brings me to, it reminds me at least of one other point I wanted to make, which is that we know about 80% of children are seen in non-children's hospitals. So this is why it's really critical that we bolster our community emergency departments to be able to meet the needs of these children and to be able to you know, advertise as such to the community.
And that way the parents would kind of know, hey, there's 2 or 3 choices. This one's already certified, or they have all the equipment. They do the quality reviews, they do the surveys, they do whatever it takes to stay approved and recognized.
That's right.
So as EMS medical directors, do you see, you know, the day that says that if you're not pediatric recognized ED, that we shouldn't take patients to you?
Absolutely not, but I do think that if there's a hospital that's not recognized as being pediatric ready, then I would discourage transportation to those facilities for those pediatric patients only. It's just that if you can't, as a medical director, I'm putting my trust in those facilities that they're able to meet the needs of my patient, and therefore I'm, you know, extending that trust to the public, which is to say to the public, I trust that this facility can care for your child, and if I'm transporting to a facility that is intentionally not pediatric ready, then I have concerns that they can't meet the needs of our patients.
So having worked with a community that has a children's hospital, it's amazing how as an EMS physician, none of the other hospitals wanted kids, but they come to the children's hospital. And so then what happens is the children's hospital gets inundated with things that shouldn't really be there. They could be easily seen somewhere else. So do you see the day that, you know, this is an ED recognition program, and so one community says, yeah, we'll do this, and the others say, no, I don't want kids, take them all there?
So certainly, I mean, if this is a voluntary program, hospitals can absolutely opt in or opt out. It would be entirely up to them. But I will say, just from example, the state of Illinois has a voluntary program, and 60% of hospitals within the entire state participate in this voluntary program. I will also say in the state of California, specifically in that Los Angeles area, they have about 73 total hospitals, of which 40 some odd are participating as EDAPs. So I don't think it's discouraging hospitals from taking kids. I think it ensures the community and develops a trust with the community that we're here to meet the needs of your children.
Does it require a pediatric ICU?
No. No, we're not talking about high levels of care. It's not talking about PICUs or NICUs or child life specialists or any of the higher levels of care. We're talking about basic infrastructure to be able to stabilize a pediatric patient with a medical illness.
And then they can be transferred.
Absolutely, they could be transferred.
So would this apply as well to freestanding emergency departments or just hospital-based?
So the way that the assessment was done, and I think that would be a decision that would need to be made among stakeholders in terms of developing a plan in the state of Texas, but the way the national assessment was done, it was any 24/7 emergency department with a physician available at each of those facilities. So. Or at least on call. So it does include critical access hospitals. Whether or not freestanding emergencies are included is a question for the stakeholders.
Yes.
So this seems to me that, you know, the way you presented it, and I've practiced in Los Angeles, and so I know exactly what you're talking about, and it's very successful there. So on many levels, this seems to be a no-brainer. So who would be opposed to this and why? What's the other side of this that I, at this point, I'm completely missing the other side, but I fear that there is an opposite side. So what might that be?
Well, this is Texas. So if I start this voluntary program, then the next thing you know, somebody's going to make this a mandatory thing, and then I'm going to have to pay somebody to come in and accredit me. And I mean, you know where the conspiracy theories go. This is right after we succeed from the union. So
I hear there may be some black helicopters coming in to enforce this voluntary program.
they are, but the aluminum plate in my head is going to keep them from talking to me. So. Jeff, you got a comment?
Well, no, it seems like when you were discussing sort of the level that they're talking about, this would be analogous to, say, a level 4 trauma center, where you're not talking about high level of capabilities.
That's correct. We're not talking about high-level capabilities. I can't speak to whether it'd be analogous to a level 4 trauma center, specifically in terms of, the details of it and what the state stakeholders would recommend in terms of what would be required for that recognition. But yes, we're talking about basic levels of care.
So my understanding, this is more prepared for pediatric patients.
That's
So
correct.
equipment, quality improvement processes, transfer agreements, things associated with caring for this special population.
Right, and we know from the assessment that less than 50% of hospitals in the United States have a quality improvement process that includes peds. We know that less than 50% of hospitals have a disaster plan that includes pediatric needs. So there are certain basic, gaps that this would, tend to promote.
You sound like a spokesperson for MSC. No?
So is this voluntary to the extent that you fill out the list yourself, or does somebody have to come and check your equipment?
I don't know yet. I think that depends on what the stakeholders would like. Is this something that would be completed on site and an application would be submitted, or would there be an on-site validation? And I think, the idea is, can we support this in concept first before we talk about how this would be implemented and when?
So we had discussions last year about another recognition program for EMS systems. Where is that going?
That's very different. So I don't know if Sam is here, but we have our first
Where's
EMS
Sam? Does
systems that
anybody
have
see Sam?
been.
Oh, there's Sam.
Sam, would you like to speak to that?
Sure, as far as I don't think that's on.
I can hear you.
That's all that's important. So as far as the EMS recognition program is concerned, we actually went up to Amarillo in March, excuse me, and kicked that program off up in the Panhandle region back in March. We have currently one EMS agency from in the Amarillo area who has gone through that process and will be getting all their paperwork turned in here shortly. Will be recognized at that gold level. If you remember, there's a bronze, silver, and gold level to that. They will be recognized as a gold level. And there are 2 other services that will be getting their paperwork submitted to go through the assessment process. That has submitted that to Perry Perkins, who is the chair of RAC 8, who is doing those assessments for us. And there are several other EMS agencies in the area that are currently trying to get the equipment together from that equipment list to apply for the process.
Good.
And we plan on piloting that program there for at least the next 3 to 6 months to make sure we get all the bugs worked out of it, and then we'll move on to a larger RAC before we spread out to the rest of the state.
Very good. Any other comments, questions? I do. I do need a motion if you would like to make a motion.
So I would move that this body vote to support the development of an emergency department approval or recognition, whatever the right verb is, for children across the state of Texas, and work with the other stakeholders to see that we can achieve that.
Motion.
Second.
Second. Any discussion? Any public comment? All those in favor?
Aye.
All right. Any opposed? All right, motion passes. Thank you, Kate.
Thank you.
Thanks, Sam. Do you have anything else you want to talk about since you're here on the agenda, or no? Should I ask that?
You know, that's always a dangerous question. However, there are a couple things. First off, next week is EMS week, as I'm sure you're all aware. Wednesday of EMS week is always EMS for Children Day, and during that time, we always present our EMS for Children Career of the Year Award. This year, the recipient is the transport team from Children's Health, Children's Medical Center in Dallas. We'll be presenting that award next Tuesday on the 17th at 10 o'clock at their hangar out at left field. So anyone that would like to come, you're all welcome. The second big thing that I would like to let you know about is, if you remember a couple months ago, I talked to you all about how the National Resource Center in Washington, D.C. was being sunsetted by HRSA, and that they were replacing it with the new EMS for Children Innovations and Improvement Center, which is going to be quality improvement based. Baylor College of Medicine in Houston applied for that grant, and just this past week, Baylor College of Medicine was awarded that grant. So the EIIC, as it will be called, is in Houston now. And so that is kind of a huge feather in the cap for the state of Texas, because all of those national meetings regarding pediatrics will now take place in Houston instead of Washington, D.C., which for me is a lot better, since that's where I'm at. So anyway, those are just a couple things I wanted to let you know.
So, thanks, Sam.
So thank you.
One other thing is that the website, I don't know if you mentioned it, for the list of equipment and other requirements is pretty readily available. It's
What is it?
Pediatricreadiness.org.
pediatric readiness software. I flipped it on a while ago. It's very user friendly. So if you just want to print out
Thanks, Bill.
the list.
Okay. Dr. Malone? Oh, I'm sorry. You did?
No, I was
Thanks, Sam.
just making sure there wasn't any questions here that I might need to answer.
Anybody want to talk to Sam?
Actually, yeah, Sam, who's going to be heading up the new institute in Houston? Who's gonna be-
So, and I'm sorry, I forgot to mention that. Dr. Charles Macias, who is the chair of the pediatric committee, he's actually the PI on the grant. Other folks who make up the executive committee is Dr. Chrisanne Graves, who is there at Texas Children's Hospital, as well as Dr. Kate Remick and Dr. Manish Shaw, who is the EMSC program director.
How
So
many
they're-
years is it for, do you know?
It is a 4-year grant.
4 year?
My assumption would be that they would look to make that a long-term.
It's a government, you can't assume anything.
That is true.
Well,
You never
that
know.
is quite an accomplishment and really great credit to the folks who applied for the grant. It reflects, as you mentioned, very well in the state for us having that body with it. So fantastic.
Thank you.
Dr. Malone, update on community paramedics? Cheers.
Sure. All right. Very quickly, we have not had a meeting between the last GTAC meeting and now, but we plan to have an additional meeting. Let me tell you where we are. We agree that there are definite areas of competence that need to be part of that instruction material. We recognize that some of the content of that is going to be probably related to the area in which the community health paramedic will be trained to serve. So certainly part of that is not, I wouldn't say discretional, but there would be more attention given into certain areas. For example, pediatrics. Dr. Remick would be one of those, right? We currently are looking at 3 curricula for community health paramedicine education, and we plan to meet before the next meeting in August and to go a little bit further with our recommendations for you. Questions?
Any questions for Dr. Malone?
Will those 3 different curricula be based on the local needs assessment, or how would you determine?
Well, actually, what we're looking at are curricula that exist, so for just not to, so the curricula from Minnesota, for example. And Jody, are you in the room? He's probably headed back for graduation already. He definitely had to be back for that. So when we actually asked for the Minnesota curriculum, they originally said, just let us know what you want. And then when we asked for it, they said, well, now we'd like a little more information. Are you going to adopt part of this? Are you going to add to it? What exactly is happening? So we're not sure whether they'll go ahead and relinquish that to us. We have the MedStars educational piece. Thank you, Dr. Beeson. And I have the material which I have been teaching at Collin College now for the last 4 years. So just knowing that you guys know this on the committee, there's just a body of medical knowledge that is a piece of this. And after that, it is making sure we can give that educational piece to them in a way that they all understand it, and then make sure that we can branch out into those sidebar areas that also need information. For example, there's going to be, we do not do home health, but there is a community piece to that, so you've got to look at what are your community needs and that sort of thing. So that's where we'll tailor that to the area specifically, but the core pathophysiology knowledge for most of these things. We can identify that. And that's what I would like to take on to Texas and say, other states are doing this. There is a need, and we can fill it as paramedics.
I know just this last week, state of Colorado now has been the next state to pass legislation for recognition of community paramedicine. So, I mean, now it's the 4th or 5th. So they're starting, and as I talked to Dr. Malone, I mean, the SIMSO has a nice process of endorsements that exist, and you know, this is an issue that we've had in Texas for years with critical care paramedics. We're going to go along the same roads here. I mean, the title's not recognized, so anybody can call themselves what they want. So I think if we're truly going to be advocates for the patients of the state, then we need to, we're citizens of the state, we definitely need to develop a process and ensure that those who call themselves this are truly what they say they are. Any questions for Dr. Malone? All right, so the next thing on the agenda, Dr. Peirce, looks like we got duplicated here, 3 and 9. So the gaps is primarily the committee working on the template for EMS medical director agreement.
So there's been no progress on that.
Okay, good, thank you. Yeah, I thought,
Well, the EMS committee this morning said they were going to give some members to a task force that were going to put with some members of this committee.
okay. So, Dr. Jarvis, while Dr. McNally comes up and gets ready, you want to kind of introduce CARES where we're going here?
Sure, there's been no progress on that objective.
What?
There has. I just was so awed by Dr. Peirce's report. I just felt jealous.
Listen, you are not to that level. You can't do that.
I can aspire. I can aspire. So we have said that as a committee we wanted to look for ways to get CARES, or cardiac arrest reporting, for the entire state of Texas. And CARES is looking at some different approaches to do that. One approach that we've been working on is asking DSHS to help fund a state coordinator. Obviously, anything that requires state funding takes a long time and is not a high-yield proposition, so that may or may not be successful. At the same time, we're continuing to look at other options. One of those options is a consortium of RACs and EMS agencies that perhaps can come together to fund this outside of the Department of Health. There's actually a meeting after this to further discuss that. Dr. Mc, where did he go?
He's right there.
Oh, there you are. I'm sorry. This is Dr. McNally, who heads up the CARES project. And if you don't mind, if you could give us an update, just an overview on where CARES is in the state of Texas, what the penetrance is in Texas, and then also give us an idea about what y'all are looking for in terms of state sponsorship. And thank you very much for being here, by the way. I hope you enjoyed the craft beers and barbecue.
I have, and appreciate the opportunity to speak. I did get a chance to speak last committee meeting, EMS committee meeting, so I'm going to give an overview. But to answer the question about current footprint, 25% of the state by population participates in CARES in Texas.
It's on, he's just not close enough to it.
All right.
There you go.
Thank you. I'm going to get the wax out of my ears, too. 25% of the states are about 6.7 million population base. Some of the larger communities currently participate, including Houston, San Antonio, Austin, Travis County have been some of the original sites participating, as well as others. I'll show you a map in just a bit. And okay, we can do it this way. This is our mission statement. I guess we'll give you the view as you're seeing here. I don't understand why.
Is it not coming up in slideshow?
No.
Okay, that's fine.
Your product is deactivated.
Yeah. Sounds like you didn't pay the bill.
Must be a state computer.
All right. So after lunch, gotta give us a little handicap here. So our goal has always been to work with as many communities as possible, but allowing a community to have basic outcome metrics for cardiac arrest, to be able to do quality improvement, to be able to benchmark, and ultimately, hopefully, to improve survival. Our vision statement is to try to work with as many communities as possible, and that's really what brought me to the meeting here, was recognizing that as we begin to expand across the country, that 90 million footprint, almost a third of the country is on board to date. It makes a lot more sense to bring on an entire state over time. And having a coordinator within that state is really part of the discussion that's going to happen after this meeting. The idea of communities being able to see their own data. A lot of the larger communities, as I mentioned, have already come on board, but there's a lot of other communities, 3/4 of the state in Texas, that are not participating. We've recognized, for example, California just bringing a coordinator on in past January. We're also working with about 1/4 of that state in population, and to bring on each county, it really helps to have somebody within that state that can help coordinate that effort. Nationally, about 1,100 EMS agencies or 1,500 hospitals participate. To date, we have 15 statewide registries where we've got a coordinator in place, and that's really what you see here on the slide is the current footprint. Green is a state where we have a coordinator. Yellow is a state where we have at least half the population on board, but not a coordinator. And then obviously red is community specific. These are the focus states that I mentioned when I presented this earlier. Obviously Texas is one of them where we have a good footprint to date. Some of the other states here, Maine is coming on board this summer, as well as Maine is already coming on board this month. New Hampshire this summer, and hopefully Vermont following. Montana just came on board last month. And a lot of this has been as a result of having some current footprint in that state and then recognizing that trying to put in part of either a full-time or part-time coordinator depending on the state's population has really helped move things forward. The goal obviously is to help a community get their own outcome data confidentially. Hospitals get to see their own data as well. That feeds into obviously the ability to generate a state or regional report where there's permissions, and then the data obviously allows us for national statistics as well. This is recommendations that came out of the recent IOM report on cardiac arrest that just was published back in June. Committee sat for almost 2 years before the report came out. These are the main recommendations they made. The first recommendation being that there be a national registry for cardiac arrest for both in hospital as well as out of hospital. And we think CARES is well positioned to help communities collect data. This is a little bit more verbiage on suggesting that CDC, who had been our funder for 8 years in advance of federal budget cuts before we transition to private funding, potentially be that lead agency again to provide resources. But we really recognize that if you want to grow a national registry, you really need to do it one state at a time. Obviously, that's where health is regulated, and really where the data can be used best, not just locally, but understanding, within a state, where are the opportunities for improvement. This is the current footprint where you see red, current agencies in Texas that participate, and then a number of others that have expressed interest and that hopefully are essentially on a waiting list as we speak. This is where we think a coordinator could help a great deal in terms of not just maintaining the existing footprint, but helping to grow future footprint. And this is actual data, the aggregate data from the communities that are participating. So about 1/4 of the state population base that's represented in the 2015 metrics. On the right, you'll see Texas data, and the left, national. And really just providing this for reference. But this is the type of data that can be used and shared for those communities that participate. The idea of being able to break down, a lot of these are not terribly different. When you have a large data set, and again, there's almost 4,600 patients that were included from Texas data last year, and almost 53,000 nationally. You can see that there are some slight differences when you look. Obviously, looking at who's the provision of bystander CPR, I think is obviously a great opportunity. In certain communities, there's really significant variation. We have certain states where bystander CPR is approaching 60%, and other states or communities where it's closer to 20. And we think that, you know, the opportunity for both community-based training as well as dispatcher presents, you know, an opportunity for overall community survival or community improvement in survival. Looking at the demographics of the event, again, these are the types of metrics that you can see at the local level. Where there's interest within a region, reports can be generated very easily. The idea is to provide the information back to the communities that participate. Obviously, looking at it, particularly in a tiered model where you may have a first responder, an advanced and unanimous provider, understanding how that system is functioning, you know, when you're responding to a cardiac arrest. Obviously, the data here is pretty similar to national data when we look at Texas in terms of an AED being applied in advance of an EMS provider. And then actually, when an AED is being applied, who is actually putting it on in terms of bystander versus first responder. Looking at ROSC, which obviously is the greatest predictor of survival outcome, you know, slightly higher here in terms of percentage in Texas compared to national. This is the same type of data that would show up on a hospital report. So a hospital would understand patients that presented to their institution, how many had ROSC in the field. That often can give a pretty good idea in terms of the likelihood for survival. And then hospitals also have the ability to look at patients that got transferred to their facility, separate from those that came by EMS, because we know there's often a lot of difference in terms of outcomes for those patients that get transferred versus those that don't. So the idea is to try to provide the data back to both EMS and hospitals so they have an understanding, to allow for benchmarking where you know, you can have a reference point from within the state, not just national data. And really looking at overall survival. Again, you know, numbers are pretty close to national data, a slight difference in actual good neurological outcome. And thankfully, very few records are missing, less than 0.5% nationally of data that's missing hospital outcome, and that's represented in the quality of the data that's been collected in Texas to date. This slide's a little bit busier, but on the left is what we call at-scene survival, or a bystander witnessed event where someone saw or heard the patient collapse, and the patient presented a shockable rhythm, a much more favorable outcome. And then on the right, that same event, but where there was actually bystander intervention. A bystander saw, witnessed the event, they presented a shockable rhythm, but they also got either CPR by that bystander or defibrillation. This is the type of data that we can also provide back when requested. We don't have the bandwidth right now to do this in every community, but we have the ability to geomap the data. We just actually finished geomapping the data for 2015. This is data that we've presented. This is Atlanta, where I live. Fulton County is the county that Atlanta primarily sits in. It sits in 2 counties. The north part of the county is very different demographically than the south part. And as you can see here, when you start looking at these 3 years of data down to the census tract level, you can see that there's clearly differences or disparity in terms of the provision of bystander CPR. The north part of the county is a higher socioeconomic distribution of residents than the southern part of the county. This is the same type of data when we grouped it, aggregate, looking at census tract data in 29 cities, and some of the communities in Texas participated in this analysis. We saw that there's a wide variation in terms of outcomes. When you look at a predominantly African-American census tract, you have a 50% less likelihood of getting bystander CPR than a predominantly Caucasian. Independent of race, when you look at income, higher income census tracts, not surprisingly, have higher rates of bystander CPR. So the idea of being able to look at data, when you have it locally, you can map it, you can graph it, but you can also begin to look at where you might put resources, if you have finite resources, to figure out which part of the community is no one doing bystander CPR and to target intervention. This is another example of data from Hawaii that was used for those that have been in Waikiki. know about ABC stores, or there's a lot of sort of 7-Eleven. And the question that came up there was, where are the public arrests occurring in Waikiki and where are the ABC stores? And might that, because they're open 24 hours, if they had the resources to put them, would there be a case that you could put these devices in stores if these events were occurring close nearby? A lot of the public arrests actually are at hotels when we looked at the actual data. But again, being able to look at trying to answer local questions as to how you might strengthen the chain of survival in the community. I'm going to end here with a little bit of data. I know you've heard a little bit about the pediatric subcommittee earlier yesterday and this idea about accrediting hospitals. This is actual pediatric. This is data that was presented at AHA. It's under review, presently for publication. And looking at national data in children less than 18 years of age, about half the arrests, or 47%, occur in the first year of life, which is obviously a very vulnerable period in pediatrics trajectory. The other half obviously occurring after. But we look at outcomes. This is looking at data with bystander CPR, less than 18 years of age, with and without. And obviously you can see there's a difference. But then teasing out, if you pull out the first year of life and look at greater than 1 year of age, you can see that there's a significantly greater benefit or perceived benefit from the provision of bystander CPR than not. That benefit does not seem to apply in the first year as readily, and obviously a much likely different event, particularly if it's a SIDS case and it's an unwitnessed event. The idea that the data can be used secondarily for research or surveillance purposes to understand where there's opportunities. This is looking at the suggestion about disparity in who's getting CPR by race in that data set and who's not. So the idea, the data can help hopefully present a better understanding of where there may be room for improvement. This is local data that's been published publicly in a county in Kansas called Sedgwick County. They did a community-based or a professional pit crew CPR program with their EMS agency in 2012. They've been participating in CARES for several years. They use CARES as a means of measuring longitudinally. Obviously, they can't say that that intervention by itself was responsible for changing data. There's probably a number of things that were going on, but the ability to track data over time, you can see that there's been a trend in improvement in survival where you see blue is Sedgwick data, where you see orange is national data, again, to use as a benchmark. I'm going to end here in just a minute. The idea that our focus has been on working with communities to measure outcomes. Obviously, having the ability to see your outcomes on an annual basis. You can log in and see that data 24/7. Hospitals can see their own data as well. But the ability to begin to focus on not just the measurement piece, but the improvement piece, working with others on developing tools like a CPR education module, as well as the ability to track dispatcher CPR as a mechanism to improve survival in the community, and looking at even high-performance CPR, something for the future, looking at trying to pull in that clinical data, something we're working on with several of the defibrillator vendors, and being able to pull it into, you could get it in the future, a standardized report. This was actual data. Zoll was the first company that's been able to pull in CPR metrics. So device marries it with an electronic patient care record. Electronic patient care record can marry it with CARES. The concept in the future would be being able to begin to look at some standardized metrics for the performance of professional CPR and not having to look at that data in two different places. So I'm going to end there, but really know there'll be more discussion in the next hour, but I appreciate the opportunity to present today.
So Brian, sorry, Dr. McNally,
Sure.
all of the data elements are defined, is that correct?
Yes. And I know there was some discussion in the last hour. We work with NEMSIS very closely in terms of developing a standard file. Some of the elements are different, and that's why we have what's called a custom NEMSIS file. But we've worked with both NEMSIS and several of the large EPCR vendors, electronic patient care record vendors, so that that data can be pulled in from the software vendor, their server to our server. But we've worked with them very closely to develop a standard data dictionary, data elements, and what we call an XML XSD file for that exchange to occur.
So, like NIMSIS has their graph of software vendors that are compliant, does CARES have a
Yep.
list also of what vendors?
Yep. Most of the vendors that people may be familiar with, there's obviously a lot of smaller vendors out there, but most of them national, we have a list. Just off the top of my head, we work with Zoll, we work with Physio or Sansio, ImageTrend, ESO, Open and Safety Pad. There's several other on the list, but those are the ones that come to mind. We have a user group with the vendors. We meet with the NEMSIS TAC meeting to try to get all, herd the cats in the same room and try to get people on the same page. So we've learned that it helps to put everyone around a table to get consensus.
Sure. Good. Question?
So, Dr. Manelli, would you mind, one of the things that we're talking about here is how we are actually able to move forward with a statewide process. Can you talk about some of the ways that other states have done this?
Sure, it's a great question. Each state we realize is different. Some of the models we've worked with have been through either state office of EMS, providing resources when available. We've also worked with, for example, in Michigan, we've worked with initially one academic medical center, University of Michigan, that said we want to expand to the state. Now 2 other medical centers are providing the resources for that coordinator, basically splitting the salary. South Carolina, we're working with the Hospital Association there. California would probably be the more recent example of working with initial grant funding to pay for the coordinator for this year and for next year. The State Office of EMS is paying the $15,000 subscription fee per year. The idea going forward after 2017 is to work with what they call the LEMSAs, or their sort of oversight body. Some of them are more than one county, but essentially 40 LEMSAs that would basically provide for resources after 2017, and kind of essentially split the check in a sense. So those are the basic models we've worked with in terms of trying to get states to figure out a way to resource the coordinator position.
And would you mind going over what essentially CARES is looking for from a state, regardless of how they go about funding it?
Sure. 2 things. Depending on the population of the state, it may be part of a coordinator's time. It may not necessarily need to be a full-time or FTE, 1.00 FTE. We think in Texas it would probably make sense to start off, if resources allow for, a full-time position. The idea is to onboard the additional communities that are not participating, and obviously maintaining data flow and the auditing process that we put in place. For example, if a hospital contact leaves, trying to reestablish a new hospital contact. Those are the types of responsibilities the coordinator piece would be. The other piece is a flat fee of $15,000 that we've developed as a business model. We've learned over time, when we had initial 8 years of CDC funding and that funding went away, the project was in jeopardy. We were thankful to get private funding. American, as I think I showed in that slide, Red Cross, Heart Association, Medtronic Philanthropy, Zoll, now more recently Physio, have provided private funding. Our first order of business at our initial board meeting was, how will we sustain this project and allow it to grow? So we looked at other registries and realized a subscription model, particularly at a state level, that may help motivate putting a coordinator in to allow for expansion, but also to sort of decentralize our labor cost. So really the 2 pieces would be a coordinator, 1.0 FTE, we think would be a good starting point in Texas, and then the $15,000 flat fee.
So just for clarifications, I mean, it's obvious that when we say state coordinator, this is not something that resides in state government, because there's no funding for this. So we, as a group of interested that's meeting here at 2:30, are trying to figure, how do we as a pool do this? And one thing that I think we need to make very clear is that if I'm a participating CARES agency, the vast majority of the workload is on me as the agency. It's not the state coordinator. I'm still directly from my EPCR vendor sending the information to CARES, correct? It's not going to the state coordinator, if that's what we call it, and then to you.
Yeah, that's correct. It's web-based software, so the data actually sits in a server securely in Minnesota with the vendor that we work with there. The coordinator has the ability to log in and see any agency within Texas. That's how we have the software set up, so they can manage onboarding a community. So if they're using EPCR in a community in Texas that wants to come on board, they would work with our team nationally to help get that get the software piece in place, doing the testing, the validation of the file, working with those hospitals to come on board and training them, which is usually about 20 minutes, with a nurse or nurse coordinator to be able to enter the cases. And then really the coordinator is, being able to figure out who's next to come on board. And then over time, when the state is mature with data, we've done this in several states, some of that energy could be focused on the improvement piece, in terms of working with communities on what are the opportunities. Are you doing dispatcher CPR training within your community, as an example, or community-based CPR training. And the idea is, you're right, it says state, but it's really a coordinator within the state. It doesn't necessarily have to have an affiliation with the government agency.
And Dr. Beeson, I think that's a really important thing, and I'd like to re-emphasize. Obviously, as Texans, we believe in local control, meaning nobody tells me what to do. The thing I'd really like to emphasize about this is if we have a state coordinator, they don't own the data. The data doesn't live on their servers. It lives with CARES.
And that's a great point. I want to add on to that. What we've developed over time, to be very clear, is the communities and the hospitals that participate in CARES and the data they share, that's who owns the data. The data obviously gets de-identified and aggregated. Each state we really suggest, and we've got a pretty good idea of how to set up a data sharing committee, which would be represented by those that participate, so that when there are requests for aggregate level data, like the slide set that I showed you here, that's something we traditionally provide back to each state. But if there was other types of requests, we're very clear that that data sharing committee should be involved in those aggregate requests, so that there's a transparency about how the data is being used. There's obviously no hard feelings. A lot of times there might be a regional request. X number of agencies say we want aggregate report.
A RAC report.
Right, exactly. A RAC report makes sense. We learned our lesson a long time ago. Everyone just sent an email that says everyone says that they want this. The state coordinator can generate the report. Just making sure that it's clear that there's a permission in place to bring that data. Anytime two agencies of data come together, there should be something that suggests that those parties want the data in aggregate form. We're very clear about not publishing hospital-specific data or EMS-specific data publicly for obvious reasons. And the coordinator, signs a non-disclosure agreement, so they understand that the data sharing committee really makes the decisions about aggregate data, local data they can manage, regional data where there's permissions they can manage as well.
Dr. Persh, can you talk about your experience, please?
So Houston was one of the, I think we're the third city to join in.
Yes.
So we've been doing this for a long time, and it has been a real benefit to us. You mentioned that less than 0.5% of the hospital data is missing, and I believe nearly all of that is from my community.
I would never point out any agency.
I know you wouldn't. That's why I'm doing it. But I do it for a reason, because as we do this moving forward, the EMS has the EMS data, but the hospitals have the hospital data, and the hospitals have got to be your partners in doing this. And I do believe that our experience has been a little bit unique. You've actually had some of your own people come and sit with us and go to the hospitals and try. So we are a little bit unique in that we had a conundrum there. But to that point, I just wanted to raise an issue and a possible point of discussion, is that there are reportable illnesses that, from a public health standpoint, that we look at, infectious disease, deaths by firearms, motor vehicle accidents. And the reason that those are reportable illnesses is that when you analyze that data, you can then translate it into action that saves lives. And I've been frustrated as an emergency physician for over 20 years now that cardiac arrest is not a reportable illness. And this isn't the time or place, but I just want it to be said on the record that at some point we do need to pick up that conversation again. And perhaps by going to a state registry, this would be one of the things to trigger that conversation.
Absolutely.
I think that, I'm just going to add, I think that's an excellent point. I think when this conversation has happened at a national level, I think what people forget is it has to happen at a state level, which you suggested, because that's where health is regulated. There's no magic wand to make this a reportable disease nationally. There is the ability, there is a group called CSTE, or Council for State and Territorial Epidemiologists, which exists that really makes recommendations for state health departments, primarily for infectious disease, birth defects, and a few others, not really specific to chronic disease or acute, cardiovascular events. They make a recommendation, but it's still the state that decides, how they want to contribute data, and making something reportable at a state level would take away some of the mystery. And I think there's some examples in Arizona. For those that may know Dr. Bobrow, he was able, I think Janet Reno was the governor at the time, and got a letter basically acknowledging that communities could participate voluntarily in their state cardiac arrest registry, but they basically took away the mystery of being able to share the data with the State Department of EMS and Trauma. And that was as a result of making sure that people didn't feel that they had a problem with contributing the data. It didn't mandate it. I think it was very smart that they didn't mandate it, but the idea is if you make something reportable, and you already have a mechanism to collect it, that's going to answer, one of the challenges. You don't want to say you have to do it and then not have a mechanism to collect it.
One thing I want to add. So now the flip side, and this is a less popular position of mine, is that I do think that at some point this data needs to become de-identified, or needs to become identified rather. And the reason is that, you showed us those graphs of their Texas versus the nation. You know what, they look really pretty similar. But you and I both know that within that, there's like bar and whisker graphs. And there are some communities that are doing much better than the rest of us. And conversely, there are some communities that are doing not so well. So the first question that needs to be addressed by those communities well, actually by all communities, but particularly the outliers, is how are they collecting data to make sure they're collecting data the same way everybody else is? And is that the reason why they seem to be so far off? And once that's cleared up, then we all need to know, those who are doing it well, what are they doing different from us? Because if we don't get there, if we don't identify those communities and find out, then to some degree I would argue this is a waste of time. It's a feel-good thing where we get to collect some numbers, we pat ourselves on the back, but if we're not going to learn something that then becomes actionable for the majority, then we're not doing it. So at some point this needs to become, we need to start identifying and get over our paranoia about don't tell anybody what my numbers are.
Just a quick question,
points.
Dr. McNally. Distinguish this product from like different guidelines.
Yeah, good question, and I'm glad this was brought up earlier. So CARES is focused obviously on out-of-hospital cardiac arrest. It's basically community-centric, meaning the event occurs outside the hospital. EMS identifies that case initially, and then we follow up if the patient obviously gets transported with hospital outcome. Again, the guidelines is focused on in-hospital, either cardiac arrest and/or STEMI, which is obviously hospital-centric. So they're not really able to give you a community-based report, and it's a really important distinction. We've developed this as a result of not knowing in Atlanta. That's how this project began. We didn't know how many patients were having cardiac arrest and were getting resuscitative efforts. We had no idea what happened after the patient got to the hospital. So this was really an initial pilot program to develop a standardized report that is community-centric and different from a hospital-centric report that just tells you these are the patients that were received at that facility. So they could collect cardiac arrest that started outside the hospital, but they'd have no idea to say, what's the survival rate in Houston or what's the survival rate in San Antonio, because they don't merge those other hospital records together. So that's the difference.
Dr. Manifold, didn't you do this at San Antonio?
Yes, and so one of my first questions and observations is this is great information, Dr. McNally. We certainly appreciate you sharing it with us, but this is one of those no-brainer things. And the real question is, why are we sitting about talking about doing it when it's really more how do we resource it? It sounds like you have scheduled to make that, have those discussions take place.
Well, I just wanted to be clear. I mean, we did it when I was in Fort Worth, and they still participate. And we did not have a vendor that automated it. It was a manual process. And it did take work. I mean, we had a position in the Office of Medical Director who did this. And we had the same problem Dr. First talked about with the hospitals, to where we ended up entering the hospital data. So we spent the time tracking it down instead of relying upon them to do it, because we couldn't get a reliable person at the hospital. So although I do agree, it's a no-brainer, it is a task. It's an important task in that agencies, I mean, we as medical directors get it, but really it's going to be our agencies understanding the importance of this, and that this is going to cost, not just the subscription and if we have to pay into the state coordinator, but within the organization, it's going to take an individual to own this process and to be able to enter the data. Getting the data out is easy. We get automated report from CARES. If you want a special type of report, either CARES staff does it, or it sounds like the state coordinator has the ability to run some reports. Lewis, can you mind talking about the individual who, I know you're like, oh crap. But Lewis, I mean, you're the person who does it here in Austin. Can you tell us about, do you mind coming up and tell us about your experiences as the actual person who does it and not just the doctor who tells you what to do?
Sure.
Yeah. I know you mind me coming up. But anyway, thanks for coming up.
Is this because I called you trouble earlier? Is that what it is?
Yeah. You're not the first. Or the last.
So Austin, Travis County, essentially, your point is a very good one. We've actually measured it, and it takes, for Austin, with the population of, for our system, 1.1 million people, we've analyzed it and determined it takes about 30 to 35 man-hours per month to actually capture all the data, including from the hospitals, get it entered, get it submitted, and it's audited by CARES. We correct the errors, and then get those, kind of back into the registry. We've been doing this since 2007 or so, with the exception of 2015. But we still say it has value, and so we have a position in our office similar to what you just mentioned. Half of that person's time is spent doing what I just described, and a portion of my time, once I get that person trained up, because I actually help with making sure our accuracy is there. So someone, I think Dr. Peirce made the comment about the difference, the variation in communities, and it likely is, because while there's a data dictionary, there's still variation in how those are interpreted. I was just talking with Jeff just a little while ago. As an example, this morning we reviewed March cases. We had 69 cases to start with. For March, we actually threw out 7 of them, because as we determined, the auto population of things from EPCR has errors. And so when we manually review them, we determined they didn't really meet the definition of that CARES has in the data dictionary of what's an attempted resuscitation. So the manual process actually gives you higher quality, but it gives you higher costs. So that's pretty much our system, but we're still doing it. Whether anything happens with the state coordinator, we still plan on doing that. But our process is really mostly manual, slight automation.
So Liz, if you don't mind, let me just clarify something. You were talking about 30 to 35 man hours to collate that data and enter it into CARES. No offense, Brian, but let's just say CARES goes away. Does your time commitment drop at all?
No.
Right. So I guess the point that I'm trying to make about this is, if you are a system that is actually analyzing what you're doing with cardiac arrest, and I would certainly hope that all of us here are doing that, you're already making a time commitment to doing that. The benefit, what we found, and the reason that we struggled so long to get together and join CARES, is because we found that actually is going to help us with the process. The amount of time we were putting into it to try to manually get all of this data and collate it was just right at the point of not being possible for us to do. So for us, it's still going to take time, but it's actually going to give us some results back.
So if I could, the comment you made, Dr. Jarvis, is exactly on target. Each agency, non-mandated, has to make that decision, just like we make decisions about other data about other patients we see. To what degree of quality are we interested in, and how much are we willing to spend to be able to evaluate how do we improve the quality of care we provide to the community. In this case, it's cardiac arrest. It could be a number of other things, but each agency has to make a decision.
And I think this gets back to Dr. Beeson's point that you have to have a champion within your system that says this is important. Whether people remain dead in the field is something that's of great importance to us. And I think that it's our job as medical directors and the clinical leaders of our systems, it's our job collectively to get together and make this point and make it to the hospitals. At some point, especially when you have a lot of competing hospitals, just like we're doing with STEMI care and stroke care, eventually you have to say, look, part of this is a partnership, and part of us bringing you patients is that you take adequate care of our patients and you give us some data back. And CARES reporting just becomes a part of that. But I think it's absolutely our job.
I agree with you, and it's more than data collection, it's doing something with the data, like Dr. Peirce or Dr. Manifold, I remember who said. I mean, it is important utilizing the data when you get it back. I know that the cardiac committee, there's been other committees that have been very passionate about certain things that are reportable diseases, like Dr. Peirce said. This is definitely one of them. I mean, in the ideal world, that this would be an automated process that goes to the state registry and then it matches up with the hospital data. But I've gotten over that delusion. So I mean, if we're gonna do it, we're gonna have to do it ourselves. And having been a CARES agency in Fort Worth, I know it's a lot of work. It's worth it. It's beneficial data. But getting others to buy off on the importance of it and what it's going to take, the time involvement to do it, not just to do it, but to do it right, I think is the important piece that people need to understand. There's no question it'll be successful in Texas, and we're going to figure how to do it. That's yet to be defined. But I mean, it was last year when we led it from this committee to GTAC, and GTAC was also supportive of we need to move forward with CARES in this state. So we've made that decision, and here we are a year later, and we're still having the conversation. It's about time to start doing something.
This discussion also brings back to the forefront a discussion that we had at our last meeting here, which was about quality improvement efforts within an EMS agency, the amount of time and actually funding that needs to be devoted to that to be able to conduct quality improvement efficiently and effectively to be able to make these sorts of changes to benefit the community. And then the other point I just wanted to say was about the, with respect to benchmarking and know you where you stand. That alone would be so helpful, even if a region just knew where their particular outcomes fell across the board, but an individual region or an individual EMS agency. And then to maybe look at those that are performing at a very high level and get information about what they are doing. It doesn't necessarily have to be pinpointed in a particular agency, but you can still get at, well, how do we compare what we're doing, since we know we're a poor performer, to what they're doing without having to go public with those outcomes?
Well, I can tell you from our standpoint in Fort Worth, it was very beneficial because, like Dr. McNally said, you can also separate the hospitals. Now, I didn't know which hospital was what, but when you provide this information to hospitals and you know that you're hospital A and you don't know who all the others are down to J, and your survival is 10% and his is 65%, that's going to make you say, well, wait a second, either I really suck or he's doing something right. So that goes along with Dr. Purse about the day of de-identifying. Because I, as a medical director, I should know that. And I mean, if I'm bringing you a patient with ROSC, and only 10% of them are surviving, but I take the bill and 60% of them surviving, either I'm bringing you the bad ones and him the good ones, which you should get down to, or he's doing something better, and I should know that to be a better advocate for my patients.
If I could ask a question, and I hope that you'll all forgive me for my relative newness here, term we used to use in the military, if that was an FNG, and I'll be happy to explain that at some other point if you'd like in another venue. My understanding after just listening in initially here is that the CARES database is itself, it currently is de-identified, and thus it cannot be used to do the types of regional and local things that we want to do, other than presumably the local people who input the information. Is that correct?
No, just to be clear, so at the patient level, to link the EMS record with the hospital, we use name and date of birth. Mm-hmm. We eventually de-identify the record of name and date of birth. We know which agency is contributing data. We know which hospitals they go to. We don't ever strip the record of that. Where there needs to be permission would be, let's say you want to have three agencies within a county that say we want a county-based report. We can generate that. We just need to make sure that you three agree that you want this aggregate report. So there is a way to bring the data back together. What we're very clear about and careful is that we would never identify your agency, and your agency publicly, or hospitals, because we don't think that's a great strategy to get people to contribute data. Plus, it's just, the idea is that the data should be used locally. The other issue that comes up when you start benchmarking, of course, is little things like sample size. Very small departments, it's going to really be hard to say year to year. If you've got 3 arrests each year, and 3 of them survive the first year, you get 100% survival, and next year all 3 die, that's 0. So little things like that, we begin to look at benchmarking. You have to look at sort of some thresholds for population, but there is absolutely the ability to generate, group reports where there's permission, and to be able to begin to look at those questions about outliers. At the hospital level, I point out too, we've looked at national data. If you survive, the patient is brought to the hospital, not obviously pronounced in the field, but brought to the hospital, the survival rate nationally is 15%. If the patient's transferred from one hospital to another, survival is 45%. So there's huge bias there in terms of who's being, so you have to look at the data when you start saying we're going to compare institutions. you know, you have to look at what's the percentage of patients that are getting transferred into an institution versus those that are coming in. You wouldn't know that if you didn't have data.
Thank you very much for that clarification and now the observation, if I may, now that I have that information. So if we're looking to do this and support it on a statewide level, there's a distinct advantage here, and that simply is that you folks have already taken the steps necessary to set this up professionally. So you have a standardized template that's going in, you have quality management, you have data management, and having had some personal experience in my own region with trying to set up something like this, and this is probably a blinding flash of the obvious for many of the people at this table, if not all. That's an incredibly difficult undertaking, and the other problem is it's an expensive one. And if we try to do that on our own, forget it. Now, on the other hand, having access to that information so that we can do regional, local, and statewide, and then compare that to the national benchmark, I see as a real advantage. And you probably already know that we're a very unique state in many ways, mostly good, I think. But our challenge here, especially in EMS, I like that, good. Our real challenge here is that we have a full spectrum, and I mean in a big way, in terms of levels of scope of practice. You know, we have professional and volunteer all over the place. We have metropolitan, we have suburban, and we have extremely rural and everything in between. And your observation about small facilities or small organizations is very well taken. You know, we have volunteer services that cover, I don't know, 1,200, 1,600 square miles of area. They might get, I don't know, 50 calls a month, and their response times are massive, and the outcomes are predictably dismal. On the other hand, you know, that number one, that's a place where we can certainly look to do resource allocation as we see. I mean, I could just see using this for some of our state grant money to target locations, and if they're not themselves applying, being able to maybe gently nudge them and say, hey, what do you think about doing this initiative or that initiative? So I would speak very much in favor of this, at least conceptually. The challenge will be, of course, finding the funding at state level, but being able to demonstrate that, I think, might be a big plus. Thanks.
Good. Dr. McNally, with the hospital integration component with this, what's across the country, what's kind of the workload that you would estimate? Are most hospitals able to provide an automated extract, or are they putting manpower time to this?
Great question. I'll say it's predominantly nurse power more than doctor power in terms of entering the data. The two questions that every hospital wants to know is, what's the burden and what's in it for us? And typically we turn it around and say, what's in it for the community? Without the hospital outcome, obviously you don't have a true understanding of meaningful outcome measure, other than if you drop them off. A big hospital, the majority of these patients, unfortunately, that are transported are going to die in emergency departments. So it's often one question. And usually when they understand that, if we can give them historical data to say last year, based upon EMS data, you got X number of patients, the majority of these are going to be one question. If they survive the discharge, 4 additional questions. We're very clear that we have supplemental fields that are absolutely optional. There's only 5 questions, and really what we're looking for is, did they survive or die? Usually they are able to log in. They don't have to go find these patients. They log into the CARES website. They're given a secure login and password. We can do training in about 20 minutes if they're a medical provider, and they basically pull up the EMR, they open up CARES, they'll see the patients they need outcomes for, name, date of birth, date of admission, they pull in the EMR, and they can find the record. I wanted to point out, I never mentioned San Antonio, a great opportunity in that community has been, I guess, health information exchange, where they're able to log in on one account and see all the outcomes in the hospital. I know that's not true in most communities, but that's an example of sort of an economy of scale where outcomes can be entered by one provider. We have that in other communities where sometimes the EMS can see the hospital outcomes they can enter. We really do try to work. We know that certain communities, they're going to want to, like Lewis has done an excellent job in terms of managing the data in Austin, and it's a manual process. We have the ability to automate it where people want to do that, but there still needs to be that oversight piece. So there still is some investment, but the idea is that hopefully over time there's less investment in data entry, and there's more investment in using the reports to try to understand how to do improvement.
And then one other question regarding with Texas, regarding the size and volume, is there a role position for a representative from the state to participate on board and or data collection committees? and such for CARES?
That's a great question. I think we're in the process right now of restructuring our board to have more representation from national organizations. So that I think there may be an opportunity. We don't necessarily have a state position, but that's something we could look at. And I think we're always open when somebody has the right skill set and interest. That's an opportunity. Our national data sharing process predominantly is by clinicians that are reviewing requests for research, and they're really looking at it critically, but there may be an opportunity there to open the scope of that data sharing. So great suggestion.
You personally have provided blood, sweat, and tears into this registry and lifelong thing. So on behalf of this committee, I think that we can certainly offer our thanks and congratulations to you for the success of the CARES program and living through some lean times and surviving is remarkable. But thank you so much for what you're able to provide for our communities currently and hopefully continue for the future as well.
Well, thank you for that. I appreciate that. And as you would recognize, a team effort. We have a team of 6, and it's really the communities that we work with in this state, particularly Dr. Peirce, Lewis, and a number of medical directors in Austin over time that we've worked with. I can't list them all. No. And
Yet to be
Jeff.
determined.
Yeah, those early adopters really helped us a great deal and continue to support. So it's been a team effort. But thank you.
Thanks, Brian. There, 20 minutes, the pop-off room, there'll be, for those interested in CARES and where do we go from here, 20 minutes, Brian will be in there with a large group of people, I'm sure. Thanks, Dr. Neal.
Thanks.
Emily, you want to come up and has there been any update on the freestanding ER task force?
We're having a meeting tomorrow. That's the only update I have.
Okay, very good.
Yep. It's
Thank
going to be tomorrow after GTAC. We're going to give everybody about 30 minutes to eat lunch and then we'll reconvene back
Okay.
here.
Tomorrow after GTAC will be a task force meeting for the freestanding emergency departments. So, Dr. Bradley, I believe, was heading up the update, or was it Dr. Moore, the transferring between interfacility transport by private vehicle? Was that Dr. Moore or Dr. Bradley? Dr. Bradley? He's not here, unfortunately.
He's not here, Dr. Bradley.
Okay, Dr. Bradley. We'll follow up on that. And then the one last thing that for my update on the mental health interfacility transfer, there's been nothing. I haven't had time to meet with the folks from the state. It's not an EMS thing as much as it's a hospital thing, but we really need to collaborate and move forward with that.
I was thinking about that. I think if we can accomplish one thing, it would be to ask the state hospitals and the private behavioral centers, what do you define as a medical screening? What are the required tests? Can we get a state requirement that they can all agree on? And avoid 15 different ways, depending on which psychiatrist is on which night.
The discussion came about was mental health facilities and the definition for inter-facility transfer. So if you're transporting somebody between a mental health hospital to, for instance, a state hospital, vice versa, the current state laws for the mental health facilities is that transport has to have a nurse on board. And we don't do that. We send them by paramedic, EMT, ambulances.
So that's from psych hospital to psych hospital, but not
right.
Private to psych.
Although, depending on who reads the interpretation, the gentleman who was here one time said that it was all facilities. So that's not the rule I read. I didn't ask any further. So,
Yeah.
All right, we'll move forward with that. Are there any other things that we need to bring up from the committee?
If you don't mind, I'd like to ask Dr. Manifold just to give an update and make sure people are aware of House Resolution 4365 DEA.
Thanks.
The role of sponsorships for House Bill 4365 continues to grow. If you're not familiar with it, I forget the actual title of the bill. I don't know if anybody can.
4365.
Yeah, something like that. It's colloquially known as the DEA bill, essentially providing single registrant change to controlled substances to be the EMS agency, and then additional rules promulgated regarding the storage and movement of controlled substances. So it continues to gain ground in the federal legislature. In the House, it will probably be meeting a conference committee for energy and commerce hopefully before the end of the legislative session. Their strategy is to get their current opioid-related bills completed so there is not confusion and/or additional concern related to that. And so that will hopefully be moving forward in the next couple of weeks. And hopefully by Monday, we will have a Senate companion bill introduced where the language will be just a little bit different to meet some of the stakeholders' needs and the legislators. So that will hopefully be introduced in the next day or two, and we'll move forward with that. So in the state of Texas, there's still relatively few federal legislatures who have signed on, and so you have your work to do to leave here. Go research quickly at House Bill 4365. You can get more information at nemt.org, nemsp.org, acep.org. I'm not sure, in government, you can get all kinds of information on it, but it really takes that personal phone call to you, to your federal legislator, to ask for their support for House Bill 4365. And if you have questions about it, I'll probably stick around for a few minutes before the CARES meeting to talk about that if you have questions.
Can I chime in?
Please.
Right, so for somebody who's been spending a lot of time talking to the DEA lately, and I won't go into any of the details and you'll understand why, I cannot underscore what Dr. Manifold just said. If your congressperson is not aware of this, then quite honestly, shame on you. The consequences for this, the way the DEA interprets the rules right now are absolutely, totally unfriendly interpretations, or at least my DEA office, towards EMS. I mean, God love them, they got a job to do, they've got a law to enforce, but these laws were written decades ago at a completely different time, and they're interpreting them the way that they're written, at least my office is. And heaven forbid you're ever in my shoes, because you will absolutely regret today that you didn't get in touch with your congress member and make them aware of what's going on and get their support.
Amen. Not to mention your patients would probably appreciate it if your medics don't have to call for an order to give a narcotic.
Yeah. That's true. All right, I did leave off number 7, work group to work on a state-approved process for rehabilitation of EMS personnel with substance abuses. Was there anybody from this committee on that? I don't remember. What's that? So, has it met yet?
It has not.
Okay, but you're heading it up, correct?
Yes, sir. The EMS committee is, yes, sir.
Okay,
So
so,
we would appreciate medical director's support and involvement if they can.
great. Do we have a medical director that's interested in working with that group? This is a group, because currently, you know, any EMS personnel that has any substance abuse issues or others there, we don't have a process like nursing and physician does to rehabilitate. And so this is something that's desperately needed. Desperately needed, yeah. Anybody interested? Well, don't everybody jump up at once. I'll help you, Dudley. Thanks.
Thank you, Doc.
All right, any public comment? No? Anything we need on the agenda for next time?
Yes, I got a request for us to try to discuss defining the elements that need to be on the form of information that our crews are leaving at the hospital. So there's a requirement to leave a form or a subset of data, but we don't really have a clear idea of what that data elements need to be. So we'd like to just discuss defining them.
So the ones that are in law aren't defined well enough?
Apparently not.
Okay, good.
I think there's some, perhaps it's an interpretation issue, but I think we'd like to make it a little clearer.
Okay.
That was my bad. Review and discuss, please.
Review and discuss, both words? Okay.
I was trying to cover for you.
Thank you.
Anything else? Thank y'all for coming. See you in August.
More people.